So I'd like to welcome all of you online and in person for the second of our AI on the Ground series. I'd like to acknowledge that we're holding this session on the traditional lands of the Kaurna people. We respect their cultural authority, and we pay our respects to their elders past, present, and emerging. Particularly in light of our conversation today, we'll be looking at issues related to the real-time deployment of models at SickKids. And Ismail is basically the guy who's behind all of that. I've had the pleasure of working with Ismail for a number of years now. And ever since he started, he was the person that we could have really in-depth conversations about these issues with, looking at different strategies for fairness, discussing different algorithmic fairness methods. And so it's really been an absolute privilege to work with Ismail over the past several years, and we continue to work together today. So Ismail is the machine learning lead at the AI for Medicine initiative at the Hospital for Sick Children. He thankfully now has more people backing him up on the machine learning side at SickKids, but he is the go-to for all issues related to clinical deployment of AI. So thank you so much, Ismail, for joining us today. I'm going to turn it over to you to get going with your talk. Thank you.
Thank you, Melissa. Hi, everyone. First of all, thank you for having me during your lecture series. In today's presentation, I will be talking about building responsible AI for healthcare, navigating challenges, and ensuring fairness. Before we start, usually when we talk about fairness, it's fairness at the research level. And when we talk about navigating challenges in deployment, usually it's post-research. However, it's rarely the case that we can do both at the same time, and we can talk about the challenges, about deployment, and the fairness when we deploy AI. I will be using one of our projects as a case study. This project is what we call machine learning medical directive, and you will hear me say medical directive countless times during this presentation. So what are medical directives? So medical directives are any order of imaging or blood tests that we can order for a patient. So it can be an ECG or a culture, a test, a blood test, or anything related to testing the patient in order to diagnose them. So at SickKids and at big metropolitan hospitals, we have a long wait time. And these, especially in the emergency department, and these wait times usually are prolonged by the medical directive orders. So you can imagine when we go to the ED journey and we ask the patients to follow the technician to get an ECG, for example, that would add a couple of hours to their stay in the ED, and that is problematic. We also need to get the results for the imaging or the lab tests as soon as possible to fast track and help with early detection, especially for the riskiest cases. And then ideally, if we can automate the whole thing, we can automate ordering the scans while we are doing or providing care for the patients or while the patient is waiting. So during the existing workflow right now is, or the existing patient journey in the ED is, first of all, a patient presents in the ED admin. They get their vital signs, healthcare information taken, then they sit and they wait. And this wait, the first initial wait phase can be up to 6 hours, and then they would be assigned to a physician. And this physician will order, for example, an ECG. They would go and a technician would come pick them up, order the ECG or perform the ECG, and then give the results back. The patient then would wait again. And then finally, the clinician, after reviewing the results of one or different medical directives, they would perform the care, and then they would offer diagnosis and drugs if needed. Now, the enhanced AI process or the MLMD augmented process is similar, where we rely on the existing workflow as a safety net. And what we would do is, first of all, we would still take the triage information, patient vital signs, physical symptoms, history, and then we would give that to an AI model and see if the AI model would predict the need for a medical exam. If the AI predicts a need for a medical exam, then we would order that medical exam in the future, long-term future, that ordering might be automatic, but for now it's human assisted. And then the technician would perform the scan while we are waiting during that initial phase of 6 hours. And then the clinician would give the care, again, diagnosis, drugs. And if not, then the patient will fall back into the existing workflow. That way, we are guaranteed to improve on the existing health care system or healthcare workflow in the ED. Now, before we talk about fairness and about deployment, I want to go over what are the tasks that we are predicting right now. And these tasks are the following: electrocardiogram, testicular ultrasound, abdominal ultrasound, appendix ultrasound, and forearm X-ray. I recognize that there is nothing, or there is nothing called appendix ultrasound. It's always abdominal ultrasound. However, some abdominal ultrasounds would focus on the lower right quarter of the abdomen, especially if we believe that the patient might have appendicitis, for example. We would focus on the lower quarter, right quarter of the abdomen. To give you history on the project, and starting from the research side, what we use as input data to the model is different from one version to another. The current existing version would take multimodal inputs, such as the vital signs, age, sex, or sex-like feature, past medical history, the CTAS score, and CTAS is the Canadian Triage Equity Score. And basically, it's a risk score from 1 to 5, 5 being the riskiest, and 1 being the riskiest, 5 being the less urgent cases. We then also have the chief complaint and triage notes, and then we use time date information, the language spoken by the patient, and then we extract the first 3 letters from the postal code. I believe, as you might know, the Canadian postal code are 6 letters, so we only use the first 3 for privacy reasons. And then we compute a couple of metrics, such as the distance to the hospital and other metrics that might be raise some questions, such as the income of the patient, and the Ontario marginalization indexes. And these are metrics provided by the Ontario government in Canada to give an overview of the different disparities or social differences within the province of Ontario. Regarding the data, right now, the model is operating in a silent trial setting. And what do we mean by silent trial? The model is operating similar to production level. However, no, we are not impacting the clinical flow. We are not impacting the clinical care, and no clinician is seeing the model predictions. However, if we look back at what we call the training set, it spans from November 2018 till June 2021. That means it covers COVID spikes. And this is very important when it comes to, for example, chest X-rays or lung-related exams. We also have a validation set which spans from July 2021 to December 2021, and then the test set from January 2022 to July 2022. You might see that we have the same number of patients in the testing set and validation set, and that's really expected since when we divided the data, we just simply divided the whole set into two. The training set, validation set, and testing set, these are retrospective data, and these are monthly extracts. However, the silent trial is operating in a real-time setting, and we have 3 minutes extract provided by Epic. And Epic is a solution that gives us access to the electronic healthcare records of the patient. The whole system now is the following. So we have the ED data, the ED hospital database. It can be Epic or other databases. We download the EHR data via one of our partners' API, and then we process the EHR data. You might see that there is different level of processing here, and this might technically be explained by processing the pulse, for example, from being systolic, dystolic in a string or into a list of character. From that to two numbers, one representing the systolic, and then the other one representing the dystolic. And then we compute and we process numerical and categorical data, and then we combine that with bioclinical BERT embeddings for the text features, such as the chart note, the presenting complaint, and the triage note. And then finally, we give that to fully connected layer, a neural network. And then if the neural network says, yes, this patient might need an ECG, then we send that to the end user, and they can finally decide if they will order the ECG or not. This system also guarantees that we can retrospectively look back and diagnose the model predictions, since we store everything during the whole process of querying the data, making inference, and storing the results. And as you can see here in green, when we say we send predictions to the end user, we only perform that during or post-clinical trial. Now, to give you a couple of results, what you are seeing here are the results for the abdominal ultrasound, where this is the precision recall curve. Ideally, since we have if you remember earlier when I talked about the safety net of the existing workflow, that means if we miss a case, then the existing workflow will catch that. That way we can focus on minimizing false errors. We would focus on the precision as a metric for machine learning, and then we can try to get the best recall numbers as possible. And here we can see that for a precision of 80%, we can get recall for about 25%. That means if we miss a case, again, it's okay, since we have our central clinical flow that will catch that. And that means out of 5 positive predicted scans, only 1 will be unnecessary, and the nurse should make that judgment to when not to order a test. And the fully automated model will only happen once the performance will improve. We can also look at the appendix ultrasound, where we have usually the same pattern of the precision recall curve. You will recognize that we target the 80% precision regardless of the recall numbers. And this is what we have for the testicular ultrasound. And then for the X-ray arm, and of course, finally, for the ECG. And I would like to focus on the ECG right now to discuss other metrics. So when we talk about fairness in AI, and I will take the ECG as an example, there is no clear pathway on how to detect it and how to mitigate the bias and ensure fairness. So we might argue for different metrics. We might hear disparate impact. We might hear precision recall ratios or positive likelihood ratio. And all of these are defined based on the following. So if we pick any random epsilon fairness threshold, then we can take two metrics. In this case, what we see here for disparate impact, we take the positive likelihood for the underprivileged group versus the positive likelihood for the privileged group, and then we compute the metric. And if that ratio is above some threshold, then we can say that we cannot detect bias. And here I'm not saying there is no bias, I'm just saying we cannot detect bias. And therefore, we can define multiple threshold regions depending on the epsilon level. So what we can see here, if we focus on the 80% 80% fairness levels, and what we are seeing that's here is in light green, then we would pick an epsilon number of 0.2. If we want to be more strict on the model and we want to have a 95% unbiased range, then we would pick epsilon of 0.05. And then whatever metric we have, which here is in purple, can vary during the fine-tuning of the threshold, and it can go from the red region, which is the bias towards the underprivileged group, and then the gray region, which is the bias toward privileged group. Now, if we apply these methods to the ECG model that we discussed earlier, and we pick the precision, we would see the following. If we, first of all, we would focus on. Okay, there is.
All right, folks, can we have everybody mute their mics, please?
What are you doing?
Yeah, thank you. So if what we are seeing here is the precision ratio. That means we divide our patients into female cohort, male cohort. We compute the precision, and then we plot the ratio based on the threshold. We can see that overall we have very unbiased model. However, I believe it's appropriate to say we cannot detect a bias when it comes to the precision. And this is expected because we are optimizing the model with respect to the precision. We are picking the best thresholds, the best models, parameters based on the precision. However, when we look at the positive likelihood, we will see the following. So you would recognize that the graph on the right is not informative on how good is the model. It only gives us information on how well a group is performing with respect to another group. So it can perform poorly on both, or well on both, or just on one subgroup. And what we are seeing here is on average, the female cohort is receiving or more likely to receive a positive prediction for an ECG scan. And this raised question when we started talking about deployment, because we don't want to have these big differences if they are not clinically explained or clinically accepted. So you might think, what does it mean if it's not clinically accepted? So if we pick an example of the testicular ultrasound, we expect to have the model predict testicular ultrasounds for the male cohort compared to the female cohort. We would have more scans. Technically, we would have no scan by the model for the female cohort and given our current data set. And when we look at this graph on the right, it raised a lot of questions. Why is this happening? Is it clearly or is it medically explained or medically valid to have these results? So to recap, on our test set, and here the test set is never seen during the training or calibration of the model. For the male versus female patients, it is on average 1.7 times more likely to have an ECG ordered for the female patient compared to the male patient. This is in the data. When it comes to the model, it varies based on the threshold, and we can go from 1.5 to 2 times more likely. I would like to attempt to explain these differences. What you are seeing here are the word clouds for in the diagnosis for patient with ECG ordered. On the left, we have the female cohort. On the right, we have the male cohort. And if anyone, I understand that it's not very easy to get the mic around, but if we can just give it for one person and ask what do they see in these two word cloud plots.
Does anybody want to start it out?
Sorry, but we're not able to see the screen fully. We just see a part of it. Yeah, thank you.
In the right.
So the right plot is the word cloud for the male cohort. The left plot is the word cloud for the female cohort. So what we see here is very expected, especially since the biggest word is chest pain, and the font size of the word is correlated with how frequent it is in the diagnosis. So since we are talking about ECG order, it is very likely to have the chest pain being one of the diagnosis or symptoms in the data. However, when we dive deep into the female cohort, we can see that eating disorder is relatively big in size compared to the male cohort. And one of the medical strategies followed at SickKids emergency department is if we believe someone has an eating disorder, we should order an ECG to check if there is something else going wrong or to understand the reasons behind the eating disorder. However, female patients in this case are more likely to be diagnosed with eating disorder. Again, just to be just to use the right words, I'm not saying female patients have more eating disorder. I'm saying female patients are more likely to be diagnosed with eating disorder. That also means male patients are less likely. Maybe they go and they might have eating disorder that go underdiagnosed. So when we talk to our clinicians and clinical champions, they explained that from their clinical experience, if the numbers are within 3 to 5 times more, let me rephrase this. If female patients are diagnosed with eating disorder 3 to 5 times more compared to the male cohort, that is medically valid. However, what we are seeing here, and when we dove deeper in, when we looked deeper into the data, we saw that 82%, roughly 83% of patients with eating disorders are female. And it is within the cohort that got an ECG and were diagnosed with eating disorder, if it is 17 more times likely to be a female patient compared to a male patient. That means there is an existing bias into the model and into the data. So let's keep that in mind. So confirmed bias, the difference in positive likelihood between female and male patients here. And then we will talk about English versus non-English speakers. can not be fully explained by medical factors. Again, if there is difference, that does not mean there is a bias. It means if it can be explained by medical factors, then that's not a bias. If not, then it's very likely to be a bias. So let's take a look at another example. English speakers versus non-English speakers. And here, to give clear definition or clear explanation to what do I mean by English speaker versus non-English speaker. So when patients join the ED, they're asked, what do you want to have as a main language? So they might speak English, however, they might feel comfortable, for example, speaking their native language. And when whatever they select is the preferred language. So if we don't have some clinician inside to translate for the patient, if they select something not that rather different from English, then we would use some translation service, online Zoom call, and we would order or we would select whatever language we want: English, French, Spanish, Tamil, Arabic, or any other language. We found out that triage notes for English speakers are on average longer than non-English speakers. And to give rough numbers, in the data before 2022, that means mainly the training data, an average English triage note length is 216.9 words. And a non-English triage note has length of 199.3 words. And the p-value for the statistical test is 0.00005. That means it is statistically significant and it is not due to randomness. I believe I am seeing a hand. Ashish? Okay, we can come back later for the question. So what we found that the model has taken that bias into the data and translated it into its prediction. And we found out that in the data, English speakers are 76% more likely to get an ECG. And when we took the baseline model that we trained, we found out that English speakers are predicted to have 73% more likely to need an ECG. Now, what does this mean? How should we address these biases? First of all, there is multiple phases where we can intervene to mitigate the biases. First of all, during the training phase of the model, we use model calibration. We can also adjust the loss function to punish the model for having these differences integrated into its performance. There is also post-training methods such as, and not limited to, threshold adjustment per group. So we would define our groups, and then we would pick different threshold per group to have similar results if it is not clinically explained, if we know that is a bias. So for example, when we look back at the example of English speakers versus non-English speakers, we would have different thresholds per language or per cross features. So for example, English speakers female, or English speakers living more than 2 kilometers away from sick kids. We can define all these groups and we can compute our useful thresholds based on that. Now, if you remember earlier in the presentation, I said we use the postal code to compute some metrics such as income or such as the Ontario Marginalization Index, and we give that as an input to the model. One might think that, is it counterintuitive? Or is it actually useful to give these features to the model? Maybe the model will be biased towards more patient with higher income. Well, we cannot claim the model is unbiased towards lower income or towards higher income, or is not unbiased at all if we don't test the model, or if we do not train the model with this feature and without. So usually what will happen is we would perform a compute our, we would train a model, and then we would report the model performance of the worst performing subgroup. So for example, if we, for the ECG model, if we have the performance on female non-English speakers living more than 10 kilometers away from sick kids and with an income less than 60%, 60K a year. If this is, if this group has the worst or the least likelihood to get an ECG, then that would be the performance of the model reported in our results. That way, we guarantee that all patient cohorts would have that, or at least that performance increase, or we are improving the care by X amount for all patients. We do not report the average performance on the whole cohort. We do not report the average, the best performance on the, or the median. We report the worst performance for whatever subgroup we have. Now, another question might be asked, how do we define these subgroups? So first of all, we have list of protective features, such as the sex, the income that we compute based on Ontario Marginalization Index and the postal code. But also, we need to be clear when we do not have a feature. For example, currently at sick kids, or historically at sick kids, we were not collecting the ethnical background information. We started doing that recently. Therefore, we don't have that information for patients within sick kid, within the training data. Therefore, we cannot claim that the model is unbiased when it comes to the ethnical background of the patient. And we need to be able to say we don't know, and we cannot predict the model performance on one specific subgroup. The best thing we can do is to start collecting the model and calibrate the model afterwards. For the audience member with machine learning and technical background, they might ask, well, we can also mitigate the bias by introducing data-related processes, such as maybe altering the labels to calibrate the data, or altering the labels to make sure that there is no bias in the data. That is certainly an option. However, we did not opt for that because the machine learning team does not have the medical knowledge to do that. And it would take a lot of resources, clinical resources, to adjust the data accordingly and to remove the bias while not altering the medical information within the data. And that's why we did not use pre-processing data bias mitigation technique. We only introduce in-process and post-processing or post-training bias mitigation techniques. Now, issue we run into with respect to deployment. So we had a data shift when it comes to the triage node length. So in February 2022, we have seen that the data or the triage node length quadrupled between February 1st and February 2nd. And that's our interpretation. It's due to some policy implementation and changes within Epic. And a solution to that is to use positional encoding to generalize from smaller training triage nodes to larger triage nodes in deployment. And we also have faced data availability failure due to network issue. And this is one of the most common challenge that we mainly all the AI model would face if they are doing real-time predictions, or if they are performing real-time predictions, where due to some network issue, we cannot collect the data, or we collect the data, but it will be delayed. So our solution was to automatically rerun these predictions based on what the network error code. However, sometimes we cannot solve for a particular technical network issue. Therefore, at that point, we will alert specific predefined stakeholders with respect to what error code we had, and that one or multiple stakeholders then would intervene and tries to solve the issue. Now, let's move on to the EHR data issues. And these are not technical issues. These are issues due to medical patterns that we have seen. So we have seen before that triage data might change 5 minutes to 4 hour post triage. However, intuitively, triage data should not change in this case. We have also seen that the longer we go after post triage, the less likely the data will change, and these change will introduce more data. So sometimes we had a mistake when we saved the patient information, so we go back and we alter, then we save it again. That way, a simple solution is to delay the inference by 15 minutes post triage to gather more information and to make sure that we have a clean data when it comes to patient information. This 15-minute threshold is selected empirically based on the frequency of the changes and the relevance, the medical relevance of the changes. Finally, the last, and this is very important, the vital signs in the historical retrospective data had different patterns compared to the real-time data. And it is expected, since when we query retrospectively, we would collect the latest vital sign. So the idea is to retrain the model using the real-time data to mitigate the differences between retrospective versus prospective data. And here, this means that we lose around 46% of our training set from November 2018 to October 2021. Why? Because while we are collecting the vital signs or the appropriate vital signs for this time period, we cannot use it when we train the data. And once we solve for all these issues, we would see the following increase in performance with respect to the ECG model, where here we split the real-time data, that means the data that we collected prospectively, into 4 sets. A training set for around 117,700 patients, and it represents roughly 60% of the real-time data. A validation set, which represents 19,600 patients, which represent 10% of the real-time data, and then roughly 19,500 patients which represents around 9.5% of the real-time data. And finally, we can run simulated prospective analysis on the last 20%. And after that, we can test a new silent trial based on the new model. And we can see that the performance increases when we add these changes and we solve for especially for the AHR data. And here we have two options. Should we guarantee the same level of precision while increasing the recall, or should we keep the same recall value and minimize the false positives in our predictions? And when we are discussing this with our clinician and clinical champions, they all agree that if we can guarantee the 1 out of 5 is false positive, and we can increase the frequency of the true positives, then that would have more impact on the whole system compared to minimizing slightly the false positive rate. Next steps for us here are adding the adequate vital signs when we are for the period of time between November 2018 to October 2021, and then addressing the downtime of an external system that we rely on, such as Epic or our partner API, and then move to build the infrastructure for the A/B testing to set up the clinical trials. And then, of course, the most important part is to have the robust clinical trial protocols approved by the REB, or the Research Ethic Board, to be able to perform these clinical trial and then compare the impact of the model on the whole cohort. And lastly, once we finalize that, we can start our clinical trials by recruiting the clinicians that would interact with the model, and then make the decision to order the scan or not. To be able to do appropriate clinical trials, we have established multimodal performance auditing. And this multimodal performance auditing means for every medical directive, we have multiple models making prediction. The production model, which this model should be unbiased as possible. Sometimes we cannot mitigate the bias, and that's okay, but we should be aware of that. And then we have a suite of models that run the inference also. And the reason for that is to keep track of model predictions based on, in case of deterioration. If over time, or it's not important, it's not an if, but when over time the model performance will deteriorate, then we can look back at the different models, the baseline, which is the first model we trained, that is biased. We know it's biased. We will not use it in production, but we need its prediction, and other models that we trained based on some ablation study. We remove the sex like feature. We remove the income, the postal code, the distance, and we see how these models would perform. And based on that, if in case of deterioration, we can look back and see and say, well, either the fairness techniques we used were the cause of the deterioration if the other models did not deteriorate, the other ECG model, for example, did not deteriorate, or if all of them were deteriorating, then another cause, such as data shifts, might be the reason, or maybe both at the same time, by the way. So we have also established a threshold-based performance termination. What does this mean? Again, when the deterioration happens, we should be able to automatically halt the predictions, or automatically alerting the stakeholder, alerting the end user based on the deterioration levels. What we have established here are two deterioration levels, or two deterioration threshold. An internal deterioration threshold where as soon as we cross that, the data science team are alerted and they know there is a deterioration, but the model is still usable. And then a hard threshold where if we cross it, we know there is a deterioration that will impact patient care, and we should halt making the prediction and sending them to the end user and inform all stakeholders, clinicians, system engineers, machine learning and AI engineers, and REB members that we are halting the performance due to the performance degradation. To conclude, I would like to give the different lesson learned here. First of all, when we are doing deployment and keeping fairness in mind, we should be aware of the assumption based on that we made based on the retrospective data. It is important not to trust these assumptions that we made using these historical data, and we must verify these assumptions through the real-time testing and validation. Next, we should also keep and monitor the updates to the external systems, such as electronic health records that can disturb the model inference. For example, during 2022, Epic updated their system where they changed from 12-hour based time format to 24-hour format, and that halted the whole system because we did not account for these changes since all the historical data had these 12-hour format. Lastly, we should prepare the system for integration issues such as network delays, interconnectivity issues between systems, all of that stuff. I believe this concludes my talk. I would like to thank the whole team behind the Machine Learning Medical Directive. They are doing amazing job, and I would like to now I would love to answer any question that any member might have.
Thanks so much, Ismail. That was fantastic. I am going to turn to Ashish first. I know he had a question. Ashish, do you want to unmute? Oh, shoot. Can we make sure that that is enabled? Yeah. Ashish, we'll get that fixed right away. I see another question in the chat. What proportion of patients end up not needing a scan in non-ML augmented queuing system? If a majority of patients are directed to scans anyway, could the number of scanners or X-ray machines and operators become a bottleneck instead, leading to similar waiting times? How much waiting time did ML augmentation save on average?
Thank you, Victor, for that question. That's very interesting. So we do not have, so I would first address the wait time gain on average. So we do not have real-time information about that since we did not do any clinical trial for now. We are finalizing the protocol for the clinical trials. However, the estimates from the retrospective and the silent trial data show that on average we can gain around if I remember correctly, 186 minutes per patient, and that should be around 3 hours. Since SickKids is known for the long wait times due to the metropolitan characteristics of the hospital. To address this other part of the question about the proportion of patients needing a scan in the non-augmented ML, it depends on the scan itself. some patient, on average, we have less than 5% of the whole cohort, which is expected since most patients in sick kids ED would not require a scan or medical directive in general. Again, these for now we are limited to the 5 medical directives that we listed above. However, we also have one of the monitoring approach that we have is the proportion of positive predictions, and if it goes beyond a predefined threshold compared to the data, compared to the reference data set, which is not the training data set. So we would compare the average positive, or not the average, the positive likelihood for a specific scan on that reference data set, and we have a predefined threshold of we cannot go above that to not order multiple scans, multiple false positive scans. However, like I said earlier, also, since the first clinical trial will be based on human interaction with clinicians that will end up ordering the scans, then we have to rely on them to make the final decision. If, for example, we order an ECG for someone with a broken leg, they will make the decision not to order that, and then they will flag it to us, and we will monitor it during and continuously monitoring these cases to understand why they are happening. So I think there is another segment of the question, or yeah. So yeah, that's it, I think.
Great. Thank you. Ashish, you should be good now, I hope.
Yep.
Yeah,
Yep.
perfect.
Thanks, Melissa. Thanks, Ismail, for the presentation. My name is Ashish. I'm a consumer advocate. I have 2 questions for you. First is that I'm assuming you're referring to a walk-in kind of an emergency department service where people walk in for a physical and in-person service. Is that correct?
Yes.
Okay. So then my question is, what is your thought? Can this service be applied to a virtual service? Because the network that I work with has a virtual care service for the pediatric emergency department. So what is your view on that?
That is a very interesting question. We actually had this kind of conversation before. However, using the model importance and the attention information from the model, we can see that the model focuses on clinical information such as vital signs and triage notes, and the nursing team is the one writing these triage notes. We had thought about having a virtual version of this. However, the current iteration of models focuses a lot on these clinical information, and the average consumer does not have the appropriate tools to measure their vital signs or to clinically diagnose or clinically explain their condition based on their symptoms. We have seen that what we call presenting complaints, basically what the patient is saying versus the triage note and chief complaint, which is what the nurses are writing. These are correlated but different. And when we only use the patient presenting complaint, basically what the patient is saying, we can see a performance degradation. That means for now, for the current version of the model cannot be extended to be used virtually, given that we cannot collect accurate and high quality clinical data.
And a follow-up question, are there any plans of looking into that space at all, virtual space?
Yes, we are still working on that. However, I can say that medical MLMT or machine learning medical directives is one of these projects that has multiple branches, from fairness analysis to deployment and clinical trial to classical machine learning research. And also we have been discussing creating a version that can, instead of saying you might need an ECG, it might say you might refer to your clinical, to your clinician to get further information in case if we believe it's an emergency compared to non-emergency. So there is different versions. We don't know what that version would be, but it certainly it cannot say you need an ECG or you need like an abdominal ultrasound, because we understand the impact on patients. If we say you need an ECG, maybe they can interpret that being you are at risk, or we might give them false information due to communication, of course, because the model predictions are numbers binary and we need humans to interpret them. And if we bypass the clinical team to automatically communicate with patients, then that adds a layer of risk that we need to be careful when we are deploying like a virtual version of this model. That's why it would be more likely this might seem condition where you want to refer to your clinician versus you can go to the ED versus it should be okay. But again, we did not decide on anything when it comes to the virtual version of the model. However, we have talked before about it, and we believe that it would have a good impact if we implement it accurately.
Okay, thanks. And I had another quick question. You made a point that triage notes for English-speaking patients were longer than the other cohort.
Yes.
So
Yes.
I was just curious, is it because the system understands their system interprets them better? In terms of,
We
is
cannot
it accustomed better to understanding English-speaking language?
we cannot talk to the reasons why the triage notes for English speaker were longer before 2022. Before February 2022, the triage notes for English speakers were longer. Yes, we cannot talk, or we cannot give explanations to that, because it's certainly a very complex question. It can be due to translation challenges. It can be due to any other factor that we cannot think about. So we just identified the issue, and then right now, currently, we are talking with the nursing team, the triage nursing team, to understand better their approach to things and what changed between 2020, before 2022 and after 2022, to be able to find a solution to that. However, like, I don't believe we have enough information to confidently explain why there is this statistical significant difference in the triage note length between English speakers versus non-English speakers.
Okay,
Thank
you very
you.
much.
I saw Alex with their hand up. I don't know, Alex, if you want to have the last word.
Sure. Thanks for a really interesting talk. I used to work in the emergency department at the Royal Adelaide, and for ECGs there, doctors don't have to order the ECG, and instead the nurses decide when an ECG is needed. And I think they have a simple criteria based on the chest pain, sync, palpitations, for example. I was wondering if your team has considered sort of non-machine learning approaches.
Yes.
If they may be comparable.
Yeah. Earlier in the research phase, when we were estimating the impact of the model, we have seen that at least at sick kids, the nurses powered by the doctor approvals are not ordering, and they don't feel comfortable ordering different scans. So the idea was to empower them with model prediction or with AI predictions, saying, yes, this patient is likely needing an ECG. However, we cannot do that immediately, and we need clinical trial first to argue for the impact of a model and to estimate the impact of a model first. So the currently, at least at sick kids, the non-ML or non-AI powered approach is useful and is being implemented. However, it's not, at least by the clinical champion estimations, it can be better if we use AI to help them with that.
Cool, thank you.
All right, thank you, everybody. Thank you to those online. Thank you to those in person. And most of all, thank you so much to Ismail. We really appreciate your time, especially under the circumstances, and wish you the absolute best for your upcoming wedding. Thank you.
Thank you.